Again, it's been a real honor and privilege to talk to you today. 2 years ago, I think I did a webinar, and it's so much better to do it face to face. And in the true tradition of a speaker, I've updated my slides literally this morning and over lunch because of all the amazing stories I've overheard. I thought, oh, I should probably put that slide in. I can really speak quickly, but I'm going to try and slow down and absolutely just go through things, and I actually look forward more to me finishing my talk so you can ask me any questions. So I'm a GI medical oncologist at University College Hospital and the UCL Cancer Institute, and I think I've been asked to do it because I've done a lot of clinical trials on immunotherapy for MSI-high cancers, and that is my research interest as well. So I don't think we need to kind of go too much into this. So we know that colorectal cancer is a growing global problem, and for you, of course, as someone who's either living with cancer or may be at risk of cancer, you know that, of course, that could be very serious for you. But again, prevention, all right? So I heard a talk recently in Belgium where someone just said, look, you know, this is totally preventable if we kind of have good information for our patients and get scoped early. And obviously, as Lynch carriers, you may already be in those kind of programs. What we definitely know is that colorectal cancer is a very heterogeneous disease, and if we understand, okay, the disease, we can diagnose it better, we can prevent it hopefully, and we certainly can treat it better. And we've known for a long time about MMR deficient cancers being hypermutated, but we couldn't really work out what to do with that for a long time. And we kind of know now when you integrate both the DNA profiling, gene expression, kind of knowing what we call the sidedness of the cancer, so we feel that biologically, okay, you've got the hindgut and foregut coming together somewhere in the transverse colon, and the right-sided tumors, that's from the ileocecal valve to the mid-transverse colon, are very different cancers, you know, completely different biology as well to the left side, and often the right-sided tumors are more likely to be BRAF mutated, which is a poor prognostic marker for bowel cancer survival, and MSI high. Obviously, as a Lynch patient, you have the risk of anywhere in your GI tract, so it's slightly less relevant. I think I just want to say, how do I explain to my patients in clinic, you know, how does immunotherapy work? And indeed, the era of COVID actually helps to a degree. So I'm sure you've heard about patients who get COVID. They sometimes do incredibly badly, and they get pneumonitis or, you know, these super inflammatory responses. So what basically happens is, let's say you do have a bacterial virus, they're presenting their antigen to your immune system, okay? So this is the HLA plus peptide, and they stimulate a signal 1 to the T cells, so they ramp it up, I'm foreign, make some things against me. Well, they're not sentient, but that's what the T cell system is trying to do. And you go through two pathways, something called CTL4 and PD-L1, in fact, to switch off your immune system once you've got enough T cells to kill it, otherwise you'll get autoimmunity. But actually, in immunotherapy, when we're trying to actually say, why are our mutated cancer cells not detected by our immune system, we actually want to help the immune system ramp it up. So you switch off the checkpoint blockers. So that's why sometimes you hear these things called checkpoint blockers, because CTL4 and PD-L1, when they are stimulated, switch off your immune system. So what you're actually trying to do is block them. So if you block the checkpoints, you just keep on ramping up the immune system, and eventually it will be strong enough to kill and recognize your cancer cells. That's a really simple way, but equally it's quite important because CTL4 blockers, such as ipilimumab, mainly hit what we call the regulatory T cells, okay, that are things that I'm thinking about. They don't really quickly kill anything, okay, but they do cause a lot of side effects. So ipilimumab can cause a lot of colitis, for example. Whereas the PD-1 blockers are more, again, it's not sentient. If you overexpress something called programmed deflagin 1, okay, essentially the cell is switching off your T cell block, okay? So you actually want to inhibit that and allow the killing, because the PD-L1 pathway upregulates something called killer CD8 cells. So these are the killer naturally which are going to kill things. And it kind of makes sense because you'll see in a moment when we're talking about immunotherapy to try and really shrink something down, it's the PD-1 blockers that do better than the CTL4 blockers. But when you combine it, wow, then you get some amazing responses. And just to say, the good thing is we've got a lot of immunotherapy checkpoint blockers on the market. It's not a closed market like at other drugs. There's so many out there. In fact, it's quite hard to choose which ones are best for our patients. But just to remember, CTLA-4 blockers basically act on your lymph nodes, whereas your PD-1 blockers act in your tumor microenvironment. Those are things that are going to kill your cancer more quickly, at least. And we know now, of course, I'm talking to a kind of a closed audience here, that the biology is dictated by the fact that we've got mismatch deficiency, okay? And I just want to show you a circuit plot. So I don't know if you knew there was something that called GEL England, which was looking at 100,000 genomes. So these are just some gel plots from some patients who had primary cancers out, and the upper one, hopefully you can see, is incredibly mutated, lots of fusions, and that is an MSI high bowel cancer patient, actually has got Lynch syndrome. And then the one which is not Lynch and MSS, microsatellite stable, you can see it is a much more benign plot. Now, we have known for a long time that, in fact, if you pick up early stage MSI high mismatch deficient bowel cancers, their prognosis is actually generally better than if you're MSS, okay? And we'll talk about, early Lynch, but we also know that it's more common, all right? So even if you're not got Lynch syndrome, MMR deficiency is probably in around 30% of stage 2 bowel cancers and around 12 to 15% of stage 3. However, if you present at stage 4, in fact, there's only about 5% of the population. So there's this interesting thing about immune surveillance that maybe that if you do pick it up early, your own immune system is protecting you from relapsing. But when sometimes it escapes the immune system, the immune surveillance, then you get very bad cancers. And that was very bad in the past, and I'll show you that immunotherapy has really transformed the care of these patients who have relapsed. And there's a general feeling of, this is a very simple way of thinking about it. Remember I was saying that if you've got a very mutated cancer, you've got more foreign proteins which are presented into the immune system. So we've talked about somatic mutations, okay? These are somatic mutations, but of course in Lynch, you're super mutated, okay? And the higher the amount of mutations you have, the higher likelihood that immunotherapy works. And that's basically what this graph shows. Again, I'm sorry that you can't, well, you can. So you've got mismatch deficient colorectal cancer here on the top right, highest number of somatic mutations, pretty good response rate. But it is not the whole answer, and hopefully by the end of the talk you'll see that nothing is, in medicine, nothing is always or never. It's always like there's gray areas and subgroups. So you can see here, for example, hepatocellular carcinomas and renal cell cancers, okay, have very relatively low mutation burden, yet have pretty good responses. So it's a bit like when John says, I don't know how aspirin works. I can also tell you, we still really don't know how immunotherapy works. But what we do know is that immunotherapy has transformed the care of patients with metastatic bowel cancer. So I'm just to show you, in the 1980s, we had nothing, absolutely zero, 5-month survival. But now with the addition of immunotherapy, and I'll show you just some data from the Keen 117 trial, we've got median overall survival not reached. That means more than half the patients on that trial have not died even after 5 years. That is amazing, okay, because normally, if you've got metastatic bowel cancer, unfortunately, if you look at the CRO statistics, it's probably only about 10% of our patients who are alive at 5 years with inoperable bowel cancer. And now, hopefully, I'll also show you that maybe we should be moving immunotherapy into the perioperative or neoadjuvant preoperative phase, and maybe we can cure more people earlier on. I've also, although I'm a medical oncologist and I like giving lots of drugs and things, we cannot forget the whole diagnostic and treatment pathway has changed hopefully a great deal. I'm sure John will say there will still have some gaps in our diagnostics. But in terms of our surgeons, our radiation oncologists doing more and more radical surgery and targeted therapies, certainly that is helping our patients. And now we've got to learn how to integrate that expertise in the era of immunotherapy. So I'm sure many of you have heard about the Keen 117 trial. And the UK actually was the first country, well, outside of the US, who approved first-line pembrolizumab for patients with metastatic MSI-high bowel cancer. I'm very proud of that fact. And I worked at UCH. We were probably the first or second highest recruiting site. And all my patients came from outside of London. So patients really traveled from Liverpool, Poole, Basingstoke, none of them really came from my site. So patients were willing to travel for this very interesting study. So the experimental arm was to give 2 years of three-weekly pembrolizumab, and the control arm had investigator choice chemotherapy plus or minus various targeted antibodies. What was interesting in a phase 3 trial, okay, where we're looking at what I call an endpoint of overall survival and progression-free survival, time to first relapse and overall survival, is there's a crossover. So most time, if you have a crossover to the experimental arm, it completely messes up the statistics, okay, if you believe truly that the drug is very good. But I think ethically, we felt that it was very difficult to not offer the patients who progressed on chemotherapy a chance of immunotherapy. One, because we already knew that immunotherapy was pretty good once chemotherapy stopped working. And secondly, I think it would have been a tragedy, really, if patients, of course, went on to study, found out that they got chemotherapy, and then quite rightly, some of them said, well, I'm just not going to go on the study. And that means this trial would have never hit any endpoints. A few other things that is not so clearly said in the talks is that, in fact, if you achieved a complete response, that means the disease completely melted away, or you finish the 2 years with non-progression, you stay on surveillance. And if you relapse, okay, you get a chance of a re-challenge of immunotherapy, which is really interesting because we don't normally do that. We don't know the outcomes. And that happens for both arms, okay? So again, no one knows this, that if you got chemo first, then progressed, then got immunotherapy for 2 years, and achieved either a complete response on second-line immunotherapy or non-progression 2 years, again, you're on surveillance, and you get another go of immunotherapy. So this trial will go on and on and on. I think a lot of these patients will get the opportunity for more treatment, even within this trial, which is great. And this is what it shows. This is the overall survival. And remember, there's a crossover. So statistically, okay, normally I say p-value of 0.05 is significant. But because of the way that this trial ran, actually statistically it didn't quite hit significance. But as a clinician, and hopefully as a patient, the curves are above each other. So that's the most important thing. And it's not just a laser pointer difference, it's a big difference. So at 3 years, we've got 61% overall survival in the Pembro first arm. And you can see even out at 5 years now, median overall survival has not been hit for the Pembro. And you see this classic, what we call plateauing, okay? So you do get some, obviously, progression and unfortunately deaths in the first year or two. But if you get past that, then actually you've got long-term survival on immunotherapy. And this is a real patient who actually, her story is in the Daily Mail if you actually want to look at it. But this is a lovely patient who wasn't very fit, 68, and had a nasty stage 2 bowel cancer resected. Wasn't Lynch, but I make no bones. I want to discuss both Lynch and non-Lynch patients here. She had relapsed with very nasty disease, lymph nodes, a mental cake, peritoneal disease, and a nasty what we call crook and bow tumor, so a tumor metastasized on her ovary. She has a lot of pain, okay? She got pembrolizumab, however, and within like 1 or 2 cycles, the pain went away. And after 6 months, it completely disappeared. Everything completely disappeared. Now, because we're lucky, where I'm looking at UCH, we could do other diagnostic tests to work out really what's going on. So we did this circulating tumor DNA test, commercial test, and it showed no ctDNA detected. And she was a BRAF mutated bowel cancer patient. So she was in radiological and technically molecular remission. And it's true, because she remains, almost 5 years later, in remission. Just to show you that we also did a solid, called a Foundation Medicine solid test. It shows she definitely had a BRAF V600E mutation and a number of other mutations. And if Ian and John look it up, there's an interesting gene here, which I'll mention in a second. But she had high mutation burden, okay, which is important. Now, I think the other thing to understand from the trial is that duration of response. So I'll show you that not everyone responded and not everyone had a long time before it relapsed. But if you take the winners, that means the group of patients who responded to immunotherapy on the first 2 to 3 months, or the patients who responded to chemo, you can clearly say everyone's doing quite well for about 4 months. And then you see the rapid drop-off in the patients who were on chemotherapy. They progressed. Doesn't mean they died, but they progressed. And it kept on going down and down and down, okay? And yet the patients who had initial response, they pretty much carried on responding. And what you can see here is that the drop-offs at each time point is less and less. So, for example, at the 2-year endpoint, 83% of the patients who had initial response were still responding or hadn't progressed, whereas only 35% of the patients at 2 years who had chemo hadn't progressed. Okay? So what's really important is patients do not want to progress in the first 2-3 months of immunotherapy, and they want to get out here to the plateau where they're probably never going to relapse. But I think the other thing that is really important, I'm very proud of us as co-authors, because we published the quality of life data. So we had the little iPad, electronic pads, and the patients were reporting all these health-related quality of life. And they talked about body image, they talked about sex life, really things that we don't normally talk about in metastatic cases, because we say the cancer is the most important thing, deal with the toxicity from chemotherapy. It's a bit complicated, but basically what it showed was that immunotherapy definitely was better for patients from a quality of life point of view. And certainly from a more general social functioning, okay, that means people going back to work, being mothers and being fathers, being uncles and aunts and grandparents, really did very well, and the fatigue was definitely nothing. And some of these patients had adjuvant chemotherapy in the past. They said, this is just nothing like chemotherapy at all. I would just say that there was one patient who actually got pretty overweight, okay, which we think was from immunotherapy, where we now think she needs bariatric surgery. So there is a side effect to maybe living. She's cured and remission, by the way, but she's gross. I hate to say it, she knows this as well. She's kind of grossly overweight, and we're thinking that she's going to have bariatric surgery, and we think it's probably a kind of off-target effect of the immunotherapy. Now, one of the major concerns is that although overall the response rate, that means that the patients on the Pembro responded more, that means a partial response or complete response was better, there was also this kind of weird thing where also more people were progressing on immunotherapy than chemotherapy. So how do you kind of work that out? Well, one of the difficult things about immunotherapy is it can work very quickly, but sometimes it can take a while to get to work. So it could take 6 to 8 weeks, whereas chemo is horrible, but it just slams the brakes on, and therefore you get some control. And some of these patients were really sick. I mean, most of my patients were pretty well coming into the study. They had the brief, but they had very bad disease. And if you don't get on top of it quickly, they could progress, because just the amount of disease that immunotherapy has to cope with is not enough. So just be aware of that, okay? There's a risk. And even when if any of you have had yet immunotherapy on the NHS, there's a bit where we have to say, you have to warn the patients that in the first 2-3 months, there's a chance that they don't do as well as if you had chemotherapy. Now, we were really lucky because the company allowed me, because I recruited so many patients, to do a secondary translational study. Now, it's very difficult to do translational research in a phase 3 setting, because it's already going to regulators. They just want to get it on FDA approval, EMA approval, NICE approval. So basically what we did was we got lots of our patients who most of them had primary resections either previously or in the palliative setting first line, and we basically massively profiled them for many things, which I won't talk about right now, but we were looking for a signal of why some patients had very durable responses and some patients didn't. So we defined that as progression-free survival. That means they did not progress for more than 12 months, or they progressed within 12 months. And we showed some very interesting things, which if you want to read it, but one of the things was, like everything, too much is too much and too little is too little. So if you had ultra-high mutation burden, you didn't actually do very well. If you had low mutation burden, you didn't do very well. Right in the middle was about right, okay? We also showed that there was a macrophage signature. So macrophages are not the normal part of the immune system we think about with immunotherapy, but macrophages mash up a lot of dead cells and things. But what we found was a particular macrophage called M2 macrophage was presenting, okay, if you had overexpression of those macrophages, they're presenting the antigens better to the T cell complex. So therefore, if you had overexpression of macrophages, you did better. Who would have known that? Okay, so this is just exploratory, okay, but now we've got to try and do it quicker and earlier for our patients. Now, a little bit of what we're doing at UCH is with one of our PhD students called Hamza, and they're basically looking at, we're about to publish this, really interesting stuff. We were actually looking at a particular type of mismatch repair, which is not just this classic MLH1, PMS2, but MSH3, which we didn't really talk about, and MHH6, which I know one of you has a mutation. So what we're actually looking at is something called homopolymer frame-shift mutations. So they're normally ignored because they think they're rubbish, as in they're not really true mutations. But what we found was that depending whether you had one, the other, or both, if you had both, you had super hyper tumor mutation burden. So it's just trying to unravel the heterogeneity of this cancer. Now, this is relevant to both patients with Lynch or not. We had 22 patients. I think 9 had Lynch syndrome. 1 had constitutive activation of the genes, and the others were non-Lynch. And it didn't matter whether you're Lynch. Now, of course, these are small numbers, but it's just interesting, okay? And the idea is that when you have too much mutation, okay, the kind of body gets a bit confused, okay? So what happens is you've got so many mutations overwhelming your immune system that the T cells get what we call exhausted. They go, okay, at the beginning it's great, we've got lots of things to kind of tackle, but oh my God, it's just overwhelming and too much. So we get this immune exhaustion, okay? There's a genuine concept we see even in other tumors, okay, where you seem to get fantastic responses, and then the T cells just shut down and say, we're knackered, okay, we can't do it anymore, and then you get immune escape, and unfortunately the disease progresses, relapses. Now, going back to that patient who had that complete response, what was very interesting was that after 3 cycles of pembrolizumab, that's just 9 weeks, we did the interval scan. She was completely well, but she had this fluffy-looking lungs, okay, and she got what we call pneumonitis, okay. This is an autoimmune side effect. So basically, her T cells were being a bit overacted, a bit like COVID, okay, but she was well. She was type 2 diabetic, and we gave her some steroids, because that's the way that you treat immune side effects. She hated it, right? Her quality of life was terrible at that point. She says, my blood sugars are all over the place. She actually, her blood pressure went up. She only had 1 kidney for various reasons. And it actually weaned off the steroids. We could not restart the immunotherapy. And then she started getting kind of terrible back pain and pelvic pain. I thought, oh no, she's got this bad BRAF mutated bowel cancer. She's relapsing in her bones. We did all these scans, and the cancer kept on shrinking. And eventually we worked out she had this tendinitis, hamstring tendinitis. So we got a rheumatologist involved, and they depot injected steroids into her hip, in the hip bones, and she loved it. So no more oral steroids, depot injections. And basically, sorry, I was totally distracted there. I want to know what she's looking at. No, what was amazing was that we could not give her any more immunotherapy, and she was in remission after 6 months anyway. So just think, this patient had 3 cycles of pembrolizumab, 9 weeks, and she's in remission 5 days later. So it just shows you how transformative this treatment can be. If she had never had this treatment before, unfortunately, normally we'd say for patients with BRAF mutated bowel cancer, with her fitness, probably dead within 18 months, okay? Her life is transformed. Now, we also know that there are side effects, okay? In fact, most of them are quite manageable. So in the Keynote 177 trial, there was only about 3% of patients who had what we call grade 3 side effects. That means side effects bad enough to bring them into hospital. It usually was diarrhea or hepatitis or some endocrine dysfunction. Most of it was manageable. But a few things to remember. One is immunotherapy is like a living drug. So we definitely see it at any time point. You can see it in the first 3 months. You can see it 3 years later, even if you stopped immunotherapy. Okay, so just be aware of that. It's also kind of a good thing, we think, because it is a living drug. You've got your immune surveillance ramped up, and the whole concept we think about immunotherapy is it is adaptive and it has memory. Okay, the whole, when you hear about chickenpox, if you get chickenpox, you never get chickenpox as an adult, you get shingles. So it's similar to that. Now, the eagle ones about you is that what I want to say is neantigen quality, therefore all these mutations are not necessarily the answer. It's the clonal or the specific mutation that might trigger your immune system. So in this very nice analysis by my colleague at the Crick and the Marsden, Sam Maturovich, who specializes in melanoma and renal cell cancers, showed in a pangenomic way that certain mutations in renal cell cancer at least, were very specific, and one was ARID1A, okay? And I don't even remember, but this patient had an ARID1A mutation. And so we can go on and on about why that is, but I'm just going to say maybe that is the reason why she had a good response. Other people said it's because she had immune toxicity, and that is the other thing we sometimes clinically see, that patients, although it's not good to get immune toxicity, sometimes they say it's not so bad, okay, because maybe at least it's working. So, the 177 trial is just the beginning, okay? Lots of questions we have to answer, and how can we select patients better? And of course, this trial was thought of 8 years ago. It really recruited very quickly from about 2016 to 2018. But now we know that maybe liver metastases don't respond so well to immunotherapy across the board. And that's, again, because we think that there's some macrophage which is doing the reverse to the M2 macrophage, is actually eating up all the things you want to try and be presented to T cells. And we know now absolutely the microbiome, I don't know if we have to talk about microbiome, but microbiome is fascinating, okay? So, you know, does the gut microbiome actually have an effect on efficacy to immunotherapy? So, very quickly, because I think you want to know about trials. So actually, there was a phase 2 trial called Checkmate 142, which was looking at second-line nivolumab, which is like pembrolizumab, versus double checkpoint nivo-ipi. And it's very small writing, but basically what I was going to say was it looks impressive, but it's certainly more toxic, okay? And although NICE have approved it, so NICE have approved second-line nivo-ipi, I would say that, of course, the patient would have had to go through first or second-line chemo first. And it doesn't talk about the patients who never got technically into the study, right, because they never were fit enough. Having said that, there are other drugs coming through. So there's another drug called dostarlimab, which I will talk about very interestingly in rectal cancers later, which is also FDA approved. So there's a lot of drugs coming out there on the market, okay, for patients who have got MSI-high bowel cancers. Now, the other thing I just want to also mention is that what if you did have chemotherapy first? How did you do? Well, even with the crossover, it was still better to have immunotherapy first. So although there's a concern that more patients progressed in the first 3-4 months of immunotherapy, if you rescued them, because they didn't die, they just went on to chemo, they did quite well on chemo. So again, this may be a concept, and I see it in other cancers, I treat stomach cancers, that if you have immunotherapy first, somehow something changes, okay, so that the response you see on standard of care second, third line treatment is a lot better than you would normally expect. So again, push the idea that unless you think you're critically so unwell that you won't get that chance of immunotherapy to get you out of trouble, you still should have immunotherapy first. And okay, I think the next question is, what do you do if a patient who does progress on immunotherapy? So this was a patient who was very unlucky, eventually Lynch syndrome, presented it 2 years ago, and he had a nasty T4N1 tumor, mucinous cancer, and it was resected, okay, and we gave him adjuvant chemotherapy, FOLFOX. He got terrible neuropathy, so we stopped after 8 cycles, and then he relapsed within 6 months with this mucinous deposits in his tummy. We did lots of profiling. At that point, we realized he was Lynch. He was the first of his family. No one else knew. He was Lynch syndrome. He had not a very high tumor mutation burden, and he was KRAS mutated. So basically, at that time, the Keynote 177 trial had closed, so I didn't really have any options. So his father, lovely guy, self-funded his son to have pembrolizumab. So how much did it cost? Quite a lot of money. At that time, probably about £8,000 every 3 weeks. So he said, okay, well, I can afford about 6 months of this, let's go. So you can see, hopefully, here, there's some little lymph nodes which are not correct. And after 3 months, it looked bad, didn't it? Look, it's growing. Okay, so he's well, but he's got what we call financial toxicity at this point. I persuade him to just push on a little bit more until we work out what to do next, and actually it shrank back down. So we do see this thing called pseudo-progression, so it's very important that your oncologist does not give up on you, okay? It's very important. We often see patients feeling very well, but the tumors grow, and we say, no, carry on, and they shrink. And if you do have a CEA rise and fall, that also helps. And we see this in melanoma and other cancers. So we're learning from other cancers too. So do not give up, or your oncologist should not give up on you if things look a little bit worse before they get better. I think this is the other thing. I'm sure you've heard of tumor boards or MDTs. So we also have a genomic tumor board. This was set up with the GEL project. So in this patient, he had a GEL whole genome assay, so we looked at that, and we're just looking for other things that would have helpful, which I won't talk about right now, but we recommended that after he had had lots of immunotherapy, okay, pembrolizumab, and then free to access nivolumab, his disease kind of stabilized, and he was very nervous. It's a single-site disease, so we resected it, so it was just in his omentum, so it was just this kind of fatty apron, and it was removed. And we did liquid, again, we were very lucky, you said we had what we call liquid biopsy, so we took a liquid biopsy, and there was a tiny fraction of KRAS mutated cDNA, so we kind of said carry on with the nivolumab. It was heading again towards COVID, and he was fed up really. He said, can I not just, hopefully I'm in remission. So after 3-4 months, we did another liquid biopsy, cleared all the cDNA, thought, okay, fair enough, stop. Unfortunately, he did relapse, okay, and then he went on to have other treatments, and he went on to have another immunotherapy drug called atezolizumab with a PIK3 kinase inhibitor because we saw that mutation on his gene profile. So again, there's lots of mutations, okay, so you've got to sort out the noise and what we call the drivers and the passengers. So we felt that would be, and he did quite well on that for 6 months. Then he relapsed. He really didn't want chemo, and I see a lot of my patients, especially with Lynch syndrome, really don't want chemo. That is last resort, okay? Anything but chemotherapy. I said, okay, very fit, and we put him on another kind of immunotherapy modulating trial with a bispecific EGFR and trying to stimulate his macrophages. Didn't really work. He's now technically on second-line FOLFIRINOX, and he's achieved stable disease, and now we're looking for another trial for him. So he's still alive, but living with his cancer, okay. Now, just very quickly, what are the things we can do? So there's a trial coming out which will just throw everything at our patients. So this trial is in America, and they basically say we're going to have FOLFOX chemotherapy with bevacizumab, with immunotherapy versus immunotherapy. And it kind of makes sense because we do this in other cancers, like in lung cancer, you can just throw the book at these patients. If they've got bad disease, get every drug under the sun, chemo, target agents, immunotherapy, and they do better. I do worry about the toxicity, and I do worry that actually as much as chemotherapy is quite good at shrinking the cancer down, you might actually get rid of some of the interesting mutations or cells that might stimulate your immune system because chemo is in itself immunosuppressive. So you might not get that great immune boost that you want from immunotherapy. So I think that you'll get a good response, probably better, but whether you genuinely pick out the patients who are going to do very well anyway on immunotherapy, I don't know, but we can talk about it. But, you know, we wait for those results. Definitely the way I think we're going is that we should use dual blockers, okay? So as much as there's more toxicity, we do this in melanoma patients. Single agent immunotherapy is not as good as doublet immunotherapy, but we have to be careful. In this small study, it was only about 45 patients, and we wait to see. And what are we waiting to see? Because really, we kind of know. So this is another Lynch patient who was not that young, 42, I think, when we found out. She had a very nasty, hope you can see here, huge mucinous rectal cancer, massive, very symptomatic. Got her onto Nivo-Ipi. You can see that it shrank down, and it now becomes from a solid, very grey tumour to a mucinous, jelly-like tumour, and it continues to shrink down, okay? However, she does some side effects. She had something called hyperphysitis and also arthralgia, but manageable with low-dose oral steroids. The other question is, how much immunotherapy do you need? So this is a patient, again, there was a silver line to COVID, so the NHS England allowed us to have immunotherapy even before licensing, okay? Because we wanted to offer, this is not just in bowel cancer, lots of cancers access to non-chemotherapy, non-cytotoxic treatments, because we wanted to reduce the risk of COVID, you know, and immunosuppression. So this not very fit woman had neoadjuvant, essentially, immunotherapy to shrink down this very nasty cecal cancer going into her psoas muscle. So again, she couldn't really walk, and within like 2 weeks of it, she could walk again. And you can see that just in 8 weeks, that tumor has shrunk down very nicely. And then she continued, she didn't want surgery actually, so we said okay, and the surgeons certainly didn't want to operate during COVID, so carry on. Then she developed this very nasty pain, and this activity on the PET scan is not the tumor, but she had essentially melted her tumor away, so there was a fistula between her bowel and her psoas. So we took her to emergency right hemicolectomy 2 days or 4 days after immunotherapy. She was fine. She was joined up, primary anastomosis, got out of hospital within about 7 days, and she had a complete pathological complete response, so no tumor in there. I just want to quickly show you that there are some trials going where we're trying to give single-agent immunotherapy versus doublet immunotherapy versus chemotherapy, but it's a really messy study, lots of arms, and it's going to close in August 25, and it opened already 2 years ago. I think the way to go is like this. So this is a study which has just opened in a few sites in the UK. That's Beatson, Villandre in Cardiff, so Beatson in Glasgow, Villandre in Wales. Coventry and me at UCL. And this is really interesting. I call this the next-gen Keynote 177, which is no chemo arm, Pembro as your control arm, and all these doublet treatments. So these are really interesting, okay? So there's something called a CTLA-4 inhibitor combined with Pembro, a LAG inhibitor combined with immunotherapy, TIGIT and ILT. So these are all like names, but I can tell you now, they're all really interesting drugs. And basically, this is a phase 2 trial, really, really rapid, and we hope again that we will recruit a lot of patients in the study. So this is the next step, that we will just be around immunotherapy backbone treatments. And I just want to show you that there's so many different ways now we might be able, okay, to profile our patients. So one is to use this kind of commercial panels, okay, rather than whole genome. We can actually now look at other things, something called PD-L1 staining, which we didn't used to do in bowel cancers, and CD8 staining, and that might actually give us some idea of how well someone may respond to immunotherapy. And these are kind of standard tests you could do. And don't forget the really rare things. So this is a young guy who had a rectal cancer with very bad liver mets. It looked like he was proficient MMR, MSS. We couldn't get more tissue, so we did a liquid biopsy, and lo and behold, he had something called a poly mutation, which is super crazy rare. It's like 0.05% chance in population, but a completely different mechanism of having hypermutation, and we got him onto pembrolizumab, and he's had a complete radiological response. So it's amazing. And I think just one of the things that I want to say is that this whole thing about mutation burden is a lovely thing to kind of jump onto, but actually it's a bit like this. So if you want to win the lottery, if you buy lots of tickets, obviously you're more likely to win the lottery. But you only need one ticket, right, to win, or Powerball 6 or something like that. So maybe it's a one or a few, and then you will benefit from your therapy. And can we do that? In all the milieu of all the things that we're worried about, pick out the winners. I want to say it's super crazy complicated. I will not go into this because I want to show you some more pretty pictures. But basically, we don't understand the mechanism of immunotherapy, and we've got to get better. So this is a trial which is called the Foxtrot trial. It was a standard trial of giving preoperative chemo for operable bowel cancers, and it will clearly show, because it's about to be published, that for proficient MMR bowel cancers, preoperative chemo is better in many ways than giving it all post-op. But for the deficient MMR patients, it was bad, okay? It did not shrink, there was still lots of tumor in the resection sample, and there was no survival benefit in relapse. Now, this is a really nice study called the Nice trial, where they literally just gave 4 weeks of nivolumab and ipi, okay, and operated on them, again, within a week of their finishing their treatment. They actually had a deficient group and a proficient group, and celecoxib is not aspirin, but they were thinking that celecoxib may help immunotherapy work in the proficient group. But what was stunning was this. This is called a waterfall plot, and this is not response rates, this is complete responses. So everyone down here had a complete pathological response. So more than 60% of the patients who had nivo-ipi had a complete response. And even some of the patients who you wouldn't see a response responded. So again, shows you that if you do it in the neoadjuvant setting, you might pick out some winners a lot earlier than you would if you have to wait in the adjuvant setting, or unfortunately when they relapse. I just want to show you, this is kind of a real life case, okay? So this is a patient who we thought had proficient MMR, okay? Proficient MMR, cecal cancer, quite old, 58, did have an endometrial cancer a few years ago, but that was also proficient. So we tried to resect, inoperable, horrible cancer here. So we gave her, as per Foxtrot, neoadjuvant FOLFOX, and it didn't really work. In fact, it fistulated, she then had a nephrostomy, she was really unwell. So, well, what do we do now? That we couldn't get more tissue, and so we did a liquid biopsy. So this is a different liquid biopsy, and super interestingly, this showed that she was MSI high, okay, with a high VUS and an interesting HER2 mutation. But the thing that completely changed her management. So we managed to get onto nivolumab on the COVID NHS guidelines, and hopefully you can see that this is her baseline post-FOLFOX, and you can see within 3 months she had shrunk down, and within 6 months you can't see it. You cannot see it. And what's interesting is, what do we do now? She wants her stoma reversed. We can't see the tumor. We might do one of these rather unusual operations where we don't take the cancer out. Okay, that's it's not normal, but this is a new era. She just wants her stoma reversed. We'll see. Now, very quickly, I am about to open in the next 4 weeks a neoadjuvant pembrolizumab study myself Okay, so this is, I thought about this idea 3 years ago, delayed by COVID and other reasons, but we're about to open it, and it's running in 5 sites: UCL in London, Glasgow, Leeds, Manchester, and Southampton. And this is what we're going to try and do. Just recruit 32 patients who have got operable stage 2 or 3 MSI bowel cancer. They could be Lynch or not Lynch. And they all get 1 cycle of pembrolizumab, but we do lots of translational work. So we'll repeat biopsies, colonoscopy, because we think that at least half these patients will have a complete response. So if they do, we'll have no tissue to work with. So they have to agree to have further biopsies, lots of liquid samples, and we track them through. And if they've got high mutation burden, they will continue with pembrolizumab for 3 cycles, then be operated within 4 weeks. Or low, straight to surgery, okay? So the main thing is that we've got the path complete response rate, which is the very quick endpoint, but lots of interesting translational work, which is what I'm interested in as well, because I want to learn why people do well or don't do well. Now, we're also very interested in where we're going to track them in what we call personalized ctDNA signature. So what will happen is we will look on the previous biopsies of what their genome looks like, or exome, and then use a special algorithm to make personalized ctDNA, and we track them through time. So we'll see how well they do on immunotherapy, and hopefully in the future they never relapse, and see what happens in the future. And just to show you, this is a real patient who is going through as a Lynch, again, new diagnosis, and very interesting story. 42, no past medical history. His father had early stage bowel cancer elsewhere in the country, but I think was not tested because he was in his 50s or 60s. Anyway, he presents in almost obstruction from a horrible sigmoid cancer, very inflammatory, really nasty, and also another cecal cancer. We did a client biopsy, and it was MLH PMS loss, but not methylated, so almost then, definitely Lynch. And he was also KRAS 12 mutated, like that young guy. But this time, instead of doing an operation, we gave him neoadjuvant immunotherapy. Look at this. After just 3 cycles of immunotherapy with no side effects, you can see, hopefully, that the light-up tumor has almost completely melted, well, not lit up at all, and this tumor has shrunk. In fact, the interesting thing for him is he doesn't want surgery, okay? And I think he's probably right. Oh, I want to show you this. So this is the slide I wanted to add. Okay, so what I don't know is maybe everyone should be on aspirin, okay, on immunotherapy, because this is a Chinese study, so even during COVID, China just went ahead and got their own PD-1 inhibitor, toripalimab, and they did tori plus or minus celecoxib. It's a small study, 17 patients in each arm, and they showed a stunning 88% response rate when they added a single-agent PD-1 inhibitor with celecoxib. Now, I don't know, John, celecoxib, is it like aspirin? Yes, okay, so who knows? I wish I had thought of that idea. But anyway, I would just be very careful. I found out because the lead investigators are very close friends of mine. They slightly cheated, okay, so they put 9 people in the study who had actually had, like my patient, FOLFOX or K-pox, didn't respond into the study, so it's not quite pure. And I just did this over lunchtime. I found out that 4 of them had Lynch syndrome, and 4 of those had tori celecoxib. So part of that massive response may be because 4 of them had Lynch and they had aspirin. Again, this is really interesting data. This came out in ASCO GI in January. This is a small study in Sloan Kettering where they were giving stage 2 or 3 rectal cancer patients MMR deficient immunotherapy. Sorry, I've got to show you this. I've got to show you this. It's very unusual, okay, to be MMR deficient in rectal unless you have Lynch syndrome. Yeah. It's absolutely, I don't believe it actually. I say, well, we've got to have Lynch. So half these patients actually had Lynch syndrome. And this is really interesting. So they were trying to not operate on these poor patients who didn't want stomas, didn't want radiotherapy, they wanted their fertility. Going back to Tracy's question, and it was really interesting. Endoscopic response was quick. So they were just scoping them and they see the tumor disappearing faster than the radiological response. So this is the other thing. In the neoadjuvant setting, don't trust the scan. So you thought I told you don't trust the scan. In the meta setting, you even don't trust the scan. You just got to trust your gut and scope, okay? And it's really interesting because at the moment, only 16 patients are in, but 11 of them have completed the treatment, complete what we call clinical response. That means they can't see the tumor, they biopsy the tumor, nothing there. But obviously the patient's incredibly happy. I've got to do this. Okay, so MSI high, the MANTIS study showed, right, non-colorectal kind of MSI high. 0% pancreas. and very few jejunal. But again, the guy who's got the jejunal cancer, I just want to show you. This is this girl was about 18 or 19 when I saw her. She had this huge mass in her tummy. It was a jejunal cancer and a cecal cancer. And she had a small biopsy just done at some marks, and we couldn't get any more tissue on her. She was anemic to 4, but they were walking around. And we got her access to immunotherapy. In fact, we were so worried about the tumor, we didn't give her Nivo-Ipi because we were about the colitis. And you can see, look, in 3 months, that tumor has gone from that to this. In fact, it shrank down so much, she actually got stricturing in her small bowel. She had to be on TPN. You know what TPN is? When you're on IV parental nutrition, okay? Anyway, got through that. Other than that, had no problems. And we kept on offering her surgery. So Mark's team were going, yeah, let's do it. I like this idea. I don't like it. You know, I'm going to take out most of my bowel and my vessels. She continued university studies, and she's great. So, you know, again, just 2 years of immunotherapy, and she's still absolutely fine. Right, this is another patient that Kevin knows. Okay, really interesting. So don't blame me. He came to me late, okay? This is my oldest patient where you'd think this probably had Lynch syndrome. But it's interesting. He had many cancers, 2 early-stage bowel cancers, early-stage prostate, a thymic cancer, and he came to me with a gastric cancer, which was operable, and we did the MMR proficiency test. It was proficient. So I thought, well, anyway, I'll send you to geneticists because it's weird. And we found out whilst he was going through chemo that he actually had an M1 mutation. So he did have Lynch syndrome. And when I went back to him and asked him why, he says, oh, I must admit, you know, when I was that young, I didn't want to know. They offered me genetic testing, but I didn't want to know. Now, he then developed a pancreatic cancer after being what we thought was cured from bowel cancer. And this time I said, mate, I'm going to have to do the standard of care of giving you chemotherapy. But immunotherapy, he said, I want immunotherapy. I said, I cannot really give you immunotherapy unless you relapse. And sadly, he did relapse. So you can see this horrible relapse around one of the margins. But we gave him, again, compassionate access Nivo-Ipi. And hopefully you can see that that tumor has almost melted away. And his CA99, which is a tumor marker, was very high, almost over 1,000, and is now almost normal. So it does work, and he has Lynch syndrome. And of course, he's going to say, maybe this will protect me from my 9th cancer or whatever he's got. I said, yeah, I hope so. So we just don't know how to improve on immunotherapy. There's many ways we could improve on it. We don't know whether it's going to be a long, what we call relay. That means there's lots of people involved in many times. What I call mixed triathlon, or it's going to be the modern pentathlon, where you run around and then you shoot the target. I wanted to add this, sorry. I wanted to add it because John said it, and I did do it 2 years ago. I would like to see this study. I haven't seen any update of this. I like this idea, okay? Forget aspirin. I mean, aspirin's great. But what about giving, as I said, pulsed immunotherapy for patients who are Lynch carriers? And maybe we don't need to do all that surveillance every year and a half, and maybe protect them long-term from any Lynch-associated cancer. Okay, yeah, fine. I'm just not going to say, I'll give you the slides. We'll give you more time. But I think really the main thing is just to be aware that, of course, I'm talking to a closed audience here, but I do think that to really understand colorectal cancer or tumor biology, these neoadjuvant preoperative studies are the way to go. So, thank you very much.
Thank you.
Sorry for running over.